All right. Good morning, everyone. We're going to start the session now. Thank you for joining us. This is session 3B, Compassionate and Responsive Care for People Who Use Alcohol and Opioids, Integrated Care Pathways in the ED. Just so that you know you're in the right place on this beautiful Saturday morning. My name is Kim Baker. I'm the Director of Clinical Services at St. Leonard's Community Services in Brantford, Ontario. And I'm your moderator for the session. So before I introduce our speakers and we get the session started, I just wanted to give you a couple of reminders. You can increase the size of the slide presentation that's being shared by clicking on, right-clicking on the presentation image and selecting Picture in Picture, and then you can resize the pop-out window. During the presentation, I would encourage you to put your questions and comments in the chat room. You can open the chat room by clicking the chat icon at the top of the screen and selecting Current Room. And then at the end of the presentation, I'll also open your ability to use your microphone, and you can ask questions by raising your hand at the end of the session. So I'm now going to introduce our speakers this morning. So Chris Cull is a two-time cross-Canada cyclist, filmmaker, motivational speaker, founder of Inspire by Example, and a recovering opioid user. Using his personal experience with opioid addiction and stories documented across Canada, Chris has advised numerous institutions and organizations in the prevention and treatment of substance misuse. His advising includes the 2017 Canadian Opioid Prescribing Guidelines for Chronic Non-Cancer Pain, Constituency Council at Centre for Addiction and Mental Health, the Substance Use Disorder Provincial Advisory Table at Ontario Health, and the Municipality of Durham Region's Opioid Task Force. Chris also serves on the Policy Committee of the Canadian Society of Addiction Medicine and the Board of Directors of the Canadian Centre on Substance Use and Addiction. Joining Chris is Hasan Sheikh, who is an emergency and addiction medicine physician at the University Health Network in Toronto and an assistant professor at the University of Toronto Department of Family and Community Medicine. He serves as the medical lead of substance use services at UHN, where he founded the hospital's RAM clinic and addiction medicine consult service, as well as leading education and quality improvement initiatives to improve the care of people who use substances across the hospital. In the last year, he has also served as the clinical lead for substance use disorders at the Centre of Excellence for Mental Health and Addictions at Ontario Health. So I am going to turn it over to Chris and Hasan.
Perfect. Thank you so much, Kim. So we're really excited to talk to you today about some of the work we're doing at the Centre of Excellence for Addictions and Mental Health at Ontario Health, and we'll talk about what that is exactly, but really focused on what it looks like to build a compassionate, responsive system for people who are using substances who are at really high risk in the emergency department in particular. Kind of how we see this as a first step towards building a more integrated and compassionate system overall. In terms of our disclosures, we've received some in-kind support from the staff at Ontario Health and the Centre of Excellence for putting together this presentation and helping us work together on it. In terms of my financial disclosures, I get some funding from an innovation fund for projects related to alcohol use disorder in the emergency department. And then I also get some financial support to be the provincial clinical lead for substance use disorders, as well as the medical lead for my hospital for substance use services. And for Chris, he receives a grant from the Canadian Society of Addiction Medicine for a film series on addiction. But in terms of the biases, there's no kind of financial relationship between the work we're doing and kind of direct financial benefit to us. And so that is a significant way that we hope that this presentation will be free from bias. So the plan for today and kind of the objectives is we really want to highlight kind of what is happening in emergency departments across the province of Ontario, but that is also reflected across the country, especially when it comes to alcohol use and opioid use. We want to talk about that as an opportunity actually to intervene and actually help support people at a time when they're facing extremely high morbidity and mortality. And then I want to introduce some of the work that we're doing at the Centre of Excellence for Mental Health and Addictions, so that you could have an idea of what it could look like, and we can get some feedback about trying to move from kind of a very reactive system of policymaking to one that is more proactive, more compassionate, more holistic, that really kind of tries to figure out how do we provide the right care at the right time for the right person. I'm going to turn it over to Chris to tell us a little bit about his journey and as it pertains to this work.
Thank you, Hasan. Thank you guys so much for being here. I appreciate all of you and the work you do. Just going to go over my story a little bit just to kind of give context as to why I got into this work and the lens that I approach it with. So where to start here? When I was, so I'm 38 now, but it's when I was 22 years old, or when I was in my late teens, actually, my dad was diagnosed with Huntington's disease. He was a paramedic for 27 years. He was my hero. After he was diagnosed with his disease, he lost his license, lost his job, lost his will to live, started drinking, developed a very heavily alcohol use disorder, and that exacerbated by the disease, it was just a spiral out of control, and where he started trying to take his own life on a fairly consistent basis. For about the 2 years leading up to his actual passing, I was coming home every single day, not knowing if that was going to be the worst day of my life, every single day. And then I started using Percocet to start trying to. I found it was the only thing that kind of calmed me down enough so I could kind of keep moving forward. And then when he, one day I was went to school, or he'd went out the day before, wasn't there when I woke up, and I'm like, okay, this is a problem. And I'm like, if he's not back when I get back, we got to figure this out. Long story short, I found that he had been at a bar the night before, and then tried to track down where he might have stayed. And then I found that I called this hotel in Bowmanville, and they couldn't tell me if he checked in, but asked me if there was a reason why he harmed himself. And then just letting my stomach drop, I knew the worst outcome was going to be the most likely one. And sure enough, show up. There's paramedics there who I'd known since I was a kid, and found him deceased in a hotel, and that broke me as a person. I didn't know what to do, and I went off the deep end, so to speak, with pills, and started using up to 580 milligram oxys a day for 2 years. And I lost everything that meant anything to me to that. Lost all the money my dad left me, his house, girlfriend of 3.5 years that I loved dearly at the time, and just devolved. And then finally came to a point where I'm like, I need to turn this around. So I had no idea what addiction services existed, if any at all. And the only thing I had heard about from the people I used with was about methadone. So not knowing what was out there, that was just my first place I went, because that was all I knew about. And methadone was its own journey. I spent 5 years on that. And then that was its own ride. And thankfully was able to slowly, it took me 1.5 years to taper off from 120 milligram daily dose, and went down all the way to half, just to ensure I didn't withdraw when I got off. And then went on to ride a bike across Canada to raise awareness and film a documentary on the opioid crisis at the time. So I rode from Victoria, BC to St. John's, Newfoundland, literally going town to town, coast to coast on a bicycle, going out in all the communities and talking to anybody who would talk to me about what was going on in their community, about what was going on with the opioid epidemic. And learned so much about that that I actually realized that I got off everything, did the ride, and then realized after learning all that stuff, I'm like, yeah, I got to go back and address some stuff if I want some longevity in this, which is a little bit backwards. But so that ended up leading into all the consulting positions that were mentioned in the introduction. So collectively, I have 8.5 years of lived experience with opioids, 9 years-ish of policy and strategy. And I recently took a position about 6 months ago working in the Emerge at Lakeridge Health Oshawa in a peer support capacity. And the lens I take to that is I know what it's like to be in crisis in there. I know what it's like to be stigmatized in there. I know what it's like to be treated like you're drug seeking because you had a broken bone. And I know firsthand what the stigma, the reality of what that is in Emerge. And what I try to be when I go there is I try to be the person I wish I had when I was in there in my own struggle, and try to show people the respect that they don't, that it's a routinely voiced to me that they don't feel they get. They feel like they're a number and machine. And I understand the chaotic environment of Emerge and short staffing and everything like that. So I try to eliminate all the anxieties by reducing all the unknowns, whether if that's just some information I can find on a chart that they don't, because more often than not, people don't know what the next step in their pathway of care is, which then causes anxiety. When I could just go over to the computer, this is what I see, this is what I think, and this is what I know, and try to, and then people appreciate that. It calms their anxiety, and then it then helps them not bother staff, because then that unknown is no longer there. But long story short, the lens I take to the work that we are doing within the Substance Use Disorder Provincial Advisory Table and the integrated care pathways is that near 20 years of the wholesale experience of lived policy and then working frontline. So I'm going to pass it back to Hasan, but that's my story in a nutshell. And looking forward to kind of digging into it a little bit more as we move along.
Thanks so much, Chris. I just want to echo so much what you said about, especially what I hear from patients all the time, is that not knowing, that kind of, that just like when you're in that space and you just don't know what the next step is, that can be so anxiety provoking and escalating for people, and it just makes such a big difference to have someone who's able to kind of guide someone through that process. This is where I work. It's a downtown urban emergency department in Toronto. And when I started working back in 2015, it was quite noticeable to me right away when I started working there that that we were just cycling patients through. We keep seeing people coming in for kind of what seemed like simple intoxication or withdrawal, and we were just kind of setting them back out to the exact same circumstances that that created that visit in the first place. And so I also found that both the patients were extremely frustrated with the care. They were frustrated about getting poked and prodded and CT scanned when they were intoxicated, and getting pushed out the door when they weren't quite ready, or they were struggling with withdrawal for longer than they needed to be. But I also found that the providers were extremely frustrated. And so that to me was a signal that there was something significantly broken in this system, in the emergency department, of how we were caring for this population. And it was in that kind of those interactions of frustration on each side that I kind of really noticed that's when so much of the stigma comes through around the way people talk about people who had substance use disorders, and the way people treat individuals with substance use disorders. And that led to us coming together at our hospital and trying to do a number of initiatives to change the care of individuals in the emergency department. So we opened up our RAM clinic, low barrier addiction medicine clinic, where people could get seen without an appointment, without a referral, just a place where they could show up after the ED to get their care continued. We did a lot of education in the Emerge, rolling out things like order sets to start buprenorphine for opiate withdrawal, start initiating anti-craving medications that people had, could take these visits that were, at the moment quite frustrating, and turn them into something more hopeful, where we could actually start kind of the treatment that people needed. We introduced peer support workers and even started an addiction medicine consult service. And I think what I've seen in that process is, I never thought that I would see this, but my colleagues kind of pick up charts of people who use substances almost excitedly, where they're like, oh, I'm actually excited to see this person because I think that there's something I can offer, something I can do to help. And that's a drastic change from what I've seen before. And I think it just goes to show how one of the major antidotes to stigma is actually having tools to offer people and having that hope that people can get better and that we're part of that journey. When we look at the data more broadly about what's happening in the emergency department, what we see is that these are some of the most vulnerable patients in our system. It's often the first point of contact for people in the healthcare system, and they're frequently not that connected to care outside of the emergency department, much more for substance use disorders than for other mental health conditions when we look at the ED data. And so this just shows that actually these are outpatients in the emergency department. I often tell learners that, when When someone's heart failure gets worse, they're more likely to call their cardiologist and get follow-up. But when someone has an acute exacerbation of their substance use disorder, they're less likely to see a specialist, less likely to see a family physician, more likely to get to end up in the emergency department. And so it actually is important that we see these as our patients in the ED and ones that we really have to take ownership of. What we see is that over time, visits for alcohol use and opioid use is increasing, and we can see just how drastically greater visits for alcohol use are than opioids, but we're seeing a pretty significant increase in opioid use visits. Anecdotally, in my practice at least, I think because of the contaminated supply, especially around benzodiazepines, where people may receive naloxone or kind of their respiratory status is stabilized, but they end up in the ED for a long time because of the benzo intoxication. What we see is provincially, and this is reflected in the data across the country as well, is opioid-related deaths and overdoses extremely high. They've really spiked since the pandemic, and they're already trending up at an alarming rate, and they've maintained that high alarming rate since then. Hence, I don't need to tell this group all of the concerns around the opioid crisis that is happening right now and the overdose crisis. But what we find is that actually mortality related to alcohol use is actually quite high as well. And we don't talk about it in the same way as we talk about the opioid crisis. And so this is a study that we did looking at what happens if you have just 2 simple visits to the emergency department for alcohol intoxication or withdrawal. Your 1-year mortality rate is 5%. And for those with 5 or more visits in the year, it's 9%. And that's about the same 1-year mortality rate that people have after a heart attack. And so, we have folks in our ED that we see 5 times in a week. And so you can think about how vulnerable this patient population is and how high risk they are, but yet we don't really see these visits in that way. We often kind of say, oh, it's a simple visit. They're intoxicated. They'll sober up. They can go when they can walk. But we really need to shift our mindset to think, oh, these are actually the most high risk people in our department. When we look at further data across the board, even just having 1 visit to the emergency department increases your mortality rate. So this was a study that looked at kind of if you have 1 visit to the emergency department for alcohol or opioid related reasons, and then looking at a matched control group of the general population. And what they found was just having that 1 visit, your baseline mortality rate is 5 to 7 times higher than the general population. And when you look at kind of the trends both before the pandemic and during the pandemic, the general population mortality rate went up. But for people who use alcohol, people who use opioids, who end up in the emergency department, that rate is double. That increase is double, just showing how these kind of societal stressors affect this vulnerable population even more. And so these are really some of the highest risk patients we have in our ED. What we also see with respect to opioids is people do end up accessing care often and quite frequently before a fatal overdose. So in the month before someone dies of a fatal overdose, about half of people interact with the healthcare system in some way. About 6% of people in the week before an overdose, a fatal overdose, are actually seen in the emergency department. And so this just, again, highlights that we need to build a system where there's really no wrong door, where whenever someone's ready to access care, we can connect them to care and initiate treatment and initiate kind of support at that moment in time. But in particular, in the emergency department, we see that there's just such a high risk population. And so when we put that all together, we really see that the emergency department is kind of this place where you have a population at really high risk of morbidity and mortality. We actually are spending a lot of resources on these individuals, but we're not getting them the outcomes they need. We're not supporting them in the right way. And with the increasing visits to the ED that are becoming more and more frequent, we really suggest that we need to take a different approach. This is also happening in a context where our EDs are crumbling, right? You can't open a newspaper without seeing stories about emergency department closures, hallway medicine, long wait times, EMS, like paramedics who can't offload patients and are waiting hours and hours, can't get back on the road. And so it just again highlights the need for us to do something different in the emergency department so that we can provide the right care to people at the time that they need it, and also hopefully offload some of that pressure in the emergency department. And finally, this all happens in a context, especially around alcohol and opioid use, where we have really good evidence-based treatments that we know are underutilized. And so the idea was that, putting this all together, that if we created this idea around an integrated care pathway that really provides the full spectrum of care and kind of wraps support around the patient at this time of high vulnerability, can we make a difference in people's lives? And it's in that context that I started at Ontario Health at the Center of Excellence for Mental Health and Addictions, which I'll tell you a little bit about just to set the context of the work that we're doing at the Center of Excellence. So the Center of Excellence was created as a standalone agency within Ontario Health. And the idea is that it would essentially be kind of the Cancer Care Ontario equivalent for mental health and addictions. And so what that means is, if you get diagnosed with a substance use disorder, we should have an idea of, what's happening in the system, what are the standards, what are the wait times, kind of what care should you be expecting you can receive, and do we have a strategy to make sure that you get that, kind of smooth transition of care and escalation of care based on the severity of illness, and making sure that we build this system that's both comprehensive and responsive. The idea was that the Center of Excellence would oversee the delivery and quality of these services and ensure that we're kind of managing our resources appropriately, doing this continuous quality improvement, making sure we're disseminating evidence and standards across the province, and implementing kind of this roadmap to wellness that was put together for the province about creating a comprehensive mental health and addictions system. And this really looks like implementing, these kind of parts of the strategy around improving quality and expanding services, focus on innovation and scaling things up and making sure that that's done in a data-driven way, and ultimately improving access. And at the Center of Excellence, they chose 4 clinical priority areas. The one that I lead is the substance use disorders portfolio, that they've kind of done this based on the major issues facing the mental health and addiction sector. As part of this, there is embedded in this work a focus on Indigenous health equity that goes through all of these clinical areas of focus to ensure that we're kind of addressing some of those major inequities that people face at the moment. The idea around this comes from some of the learnings from places like Cancer Care Ontario, Ontario Renal Network, and other places that they've done these provincial clinical programs. And the idea is to make sure we're kind of putting all these things together in a way that fits. So, a focus on data and being evidence-based and evidence-driven, making sure that we have kind of this planning and performance management system, so that we're being proactive about policymaking as opposed to reactive and kind of just funding things in a siloed way randomly, which is unfortunately what has been happening for most places in the country for many, many years. And really focus on engaging the right people, bringing people to the table so that we have a broad representation from across the sector, and making sure we help people navigate the system, and that we keep monitoring the performance of that. So to help us do that work, we created the provincial advisory table, and there's about 20 individuals who sit on this table, and it's a combination of frontline providers, researchers, public health experts, clinical leaders, people with lived experience, like Chris, who fits into a number of these buckets as a frontline provider and someone with lived experience and someone who has expertise in the system. And the idea, was to say, can we do both these things at once? Can we take frontline experiences? And as a frontline provider, there are so many times I've been frustrated that, I wish we could take this learning and go impact the system. but can we combine those frontline experiences and a system level view to really keep improving the system and making it high quality, making it integrated, and keep doing this in an iterative way? So this table provides recommendations to the Center of Excellence that then kind of advises the ministry on how to create kind of a standardized evidence-based and high quality clinical program. And again, it's really this idea of shifting from what has so far been very reactive and siloed policy making to something a lot more proactive. And so that's where, when we came together as a table and we kind of talked about different places to start, you know, realizing the system is so large and complex, and if we try and, you know, fix everything at once, we're going to end up fixing nothing. The idea was, can we start somewhere? And so let's, you know, we came together and decided we would start with this population ED for all the reasons I just had outlined before. And so this is a super high risk population, ones where we have treatments we can initiate and ones where we have an opportunity to intervene. And the objectives we kind of have put together and vetted and kind of gone back and forth with different stakeholders in the system is that this program is hopefully going to improve access. It's going to help build connections between the hospital and inpatient services and the hospital and community services, because the emergency department kind of straddles the hospital and the community world. And this actually can be, if we can integrate care around the emergency department, then we can have our first step to integrating care throughout the whole system. Ultimately, we want to reduce morbidity and mortality, and we want to reduce inequities as well in the experiences people face. And we want to do this in a data-driven way. To help us have a structure and how to approach this, we basically took the journey of someone in the emergency department and tried to split it up into different buckets of care, which Chris is going to go through in a minute, of kind of what people need. And this has been a really interesting process, because we've gone through this over months, back and forth with lots of iterations. The names of the buckets have changed, the components have changed, but it was really helpful to have this structure to figure out what is it that people need in the emergency department. And these are the things we've kind of settled on. They need a supportive environment, they need peer support, they need the full spectrum of substance use healthcare, they need access to harm reduction services and supplies, and they need really importantly, care transition and navigation. And so the idea is that you end up, you know, if you end up in the emergency department, you get high quality evidence-based care that's respectful, that's compassionate, that's trauma informed, and then that care is started and then continued and transitioned, whether it's into the hospital or into the community. And kind of the major transition points in that system are going to look like RAM or RAM type clinics, harm reduction services, and withdrawal management. So I'm going to turn it back over to Chris to talk you through kind of some of the discussions we've had about the individual components of these parts of the system or parts of the emergency department care, and then we'll keep going from there.
Great, thank you. So I'm just going to read through these, but I'm just going to interject little tidbits as I'm going along. So just based on my experience. Supportive environments is trauma-informed, culturally safe, anti-oppressive approaches. Client-centered approach, empowering individuals to reach their goals along the substance use care continuum. Clients at risk of self-initiated discharge and therefore at higher risk of poor outcomes are identified and care is escalated. Within that last point, I find that my whole, within my role at Lake Ridge, I've been tasked with help do a reimagining of what peer support, because there hasn't been anyone in that position since prior to COVID. And what I've done is I've really prioritized my work around where the people are most likely to slip through the cracks. The number one I start at is right past triage, because you have no idea what's going on, what your next step is, and when you're going to get called. And that's when people get impatient, tired of waiting. They don't see that anything's going to happen, and then they end up walking out the door. So being able to engage those people who come in at those critical times to help them know that, yeah, we're here. We know that you're here. You want to sit down and chat and just kind of get what's pent up inside of you out just a little bit, so we can make this process a little bit more. You want a drink or food, which is the ultimate way to win over anybody in life, much less in an emerge. But it's about getting people, because the more confidence anybody can have in a pathway of care, the likelihood of a positive outcome is going to increase. So that it's all around centered around making sure we're not losing people. I'll just go to the next slide there, please. So yeah, going back to within peer support. So it was very new to me going into that role. I had never done frontline work before, but I knew what it was like to be the person on the other end. I knew what it was be there in crisis on a Form 1 and like many years ago. But I remember how that made me feel, and I remember how I was treated, and depending on whomever I was dealing with, what kind of day they were having really dictated what day I was having. So being now interjecting peer support in it, you can alleviate a lot of that and have almost a liaison between the individual going through it and then the staff, and because it's just a different relationship dynamic, and you can bypass a lot of the potential for a lack of empathy, for lack of better wording, by the healthcare professional if they're having a bad day. And like it's a bit troubling kind of seeing some of this, like some of the stuff that I've seen in there, because there is a lot of stigma in emerge, and there is and not by any stretch of imagination, but everybody, but it exists. And what I try to do is try to be the barrier between that stigma and the patient. So being able to sit down with them, listen to them, make them feel they're heard. And then once I start building the trust, then I can start influencing it. But all of that is revolved around creating a more positive experience for the patient, because the more positive, the more confidence anyone has in their pathway of care, the more likely, well, one, their anxieties are going to go down, but the more likely they're going to stay in that pathway of care, have confidence, and within that confidence, hopefully create a positive outcome. And we'll go to the next slide, please. So substance use healthcare. So ED staff, sorry, I gotta squint in here. ED staff using motivational interviewing to support discussions around client goals. I understand also in an ED that just time-wise staff shortages, that might not always be possible. But again, that's where you can interject somebody like a peer support or a crisis nurse to help facilitate all that. EDs have order sets of management and discharge of clients who use opioids and alcohol. ED provides the following evidence-based medications with opioid withdrawal and opioid use disorder: buprenorphine, methadone, short-acting opioids, take-home naloxone. EDs provide the following evidence-based medications for alcohol withdrawal and alcohol use disorder. And forgive me if I butcher any of these names, but it's naltrexone. Sorry, I'm squinting here.
Chris, I can chime in here. So this is, the medications they've listed there, naltrexone, acamprosate, gabapentin, some benzodiazepines, phenobarbital. Really, the idea is that we've come together as a group, and this has gone through many iterations, to say, we really want to be quite deliberate about what we think should be the standards. And then, obviously we have a lot of work to do to figure out how this is going to actually get implemented. For example, we've tried implementing things like, having methadone in our emergency department, and there's a lot of challenges with that. But, our starting point was what's the right thing to do for the patient. And then we're going to be doing a lot of work to figure out the how. But the idea is that these should be available in every ED, and then they should be started and then continued as outpatients. And then also that to be able to do that work, especially in the context of a very busy emergency department where there's a big surge in volumes, we will actually need to better support the emergency department with staffing like peer support workers and what we've outlined here in addiction medicine consult service that's at least available for support and kind of telephone advice. Chris, you're back. Perfect. Okay. You disappeared for a little bit there, but I'll turn it back over to you for harm reduction.
Yeah, so harm reduction supplies and instructions on how to use that, those are absolutely critical. At the stage we're at within with opioids and alcohol, absolutely critical to start finding ways to, well, as it says, reduce the harms within it. I come from a harm reduction background myself, but also come through the recovery, so I can see both sides of the coin. But I can't stress enough how critical it is for people and within a toxic supply and everything. I don't need to lay it out for you guys, but we're in a bad spot, and we need to start kind of easing that weight, and we need to start so we can start moving forward. Clients who self-initiate discharge are offered harm reduction supplies, education, and information. The bottom line is you're not going to get through to everybody. It's naive to think you will, but the people that if we can get a chance to get to them and at least give them that little boost to maybe hopefully get them back to the point where they are ready to seek out the help. If those harm reduction supplies are the difference between getting them to that point and not, then I think we should be doing everything in our power to do so. And what's the next slide? So care transition navigation. So part of my role within peer support, I'm on the hospital to home team. So I work within Pinewood, which is our addiction service, and Durham Mental Health Services and CMHA. And we coordinate together around all of the patients in inpatient, but also in emerge, and try to start actually connecting them with the service navigation. Like I said at the beginning, like I went to methadone because I didn't know where else I could go. Like it just is what I just had no idea. And now being able to actually offer as many solutions as possible and as many different pathways, with every different pathway, you're increasing that margin of the ability to create a positive outcome ever so more, the more pathways you can create. So the transfer of care occurs in the presence of care providers and clients possible. ED client navigators facilitate care transitions from ED. The client information is transferred from the ED to the respective hospital and or community services. Initiated treatment is continued during care transitions. Clear expectations for hospital and community services are part of the integrated care pathway, including timeliness of access to services. Now, within that, the caveat is that the community services are pretty stretched, at least where I live, where they're pretty stretched thin as it is. And it's making sure that we're also guiding the people that have capacity for services to continue on, because the last thing you want to do is be sending someone off and then them hitting a dead end when they get there. Because I think if that's the pathway we sent them on, then we set them up for failure. So I think this should be as much of a discussion as figuring, I mean, I know we're going through a health human resources issue right now, but we need to start creating capacity because communities are growing, but systems are not. We have to really find a way to start moving forward and being able to kind of not silo ourselves. And we need to utilize all the community service, get everybody on the same page, running through the same information, so we can actually start tackling it wholesale as a community rather than an individual hospital or individual community service.
Thanks so much, Chris. So in terms of that, and that leads, I think, into the next steps, which is, the first step, the way we want to do this, because this is a major change to the system. And it is going to require some additional resources, as Chris has alluded to. Systems have not kept up with demand and having grown. And so if we're expecting to do more, we're going to need kind of more resources to do that with. And so that's where we're hoping for some kind of targeted investments around selecting phase 1 sites to kind of really roll this out, for us to learn from those phase 1 sites and to select sites that are a bit different, so we can learn both kind of what's happening in different sizes of centers, different geographies, kind of different little flavors and different lessons we can learn, and then to take those learnings to scale up for our kind of secondary sites that we roll out. Part of this is going to be a really robust performance measurement framework, because we want to make sure that we're accountable to the people we're trying to help. And the only way we can do that is if we measure what we've done. And then really kind of rolling out those phase 1 sites. And in the same kind of time, working with the looks like I'm gone. Am I gone? Okay.
You're
No,
back on now.
we can still hear you, Hasan.
Ideal.
Your slides are gone, but we can still hear you.
Okay.
All right, so that's a little mistake here. Oh, there we go.
We could still hear you, Hasan, so you can pick up right where you left off.
Okay. Not sure how long you had to stall for, Chris, but or where I got off, but at the point I realized there was no one looking back at me. But yeah, so the idea is we kind of roll out the phase 1 sites, gather some learnings at the same time, starting to look at what's happening in the rest of the system and figuring out where we need to bolster services for those secondary sites to be able to do this as well. And really looking at refining the pathways based on the feedback we get from the phase 1 sites. It seems like a lot. This was actually the minimum program expectations we came up with. There was a ton of stuff that our advisory table really wanted us to include as well, that we had to say, we really want to make it as minimum as possible so that we give it every chance of actually being implemented. But obviously there's a ton more we can do in the system, but we wanted to make sure we started somewhere. So really, to put it all together, the emergency department is a place that's under tremendous strain. Visits are frequent and increasing. The population is at high risk of morbidity and mortality. And we have so far done policymaking in a way that's fairly siloed and reactive. And so if we're building to a more proactive, more integrated system, we can start in the emergency department, we can intervene at a really high risk time for people, and we can take what is currently quite traumatic visits for people, or quite uncomfortable visits for people, and actually turn them into something where there's hope, where there's compassion, where there's support, and kind of the first step for someone's journey, regardless of what their goal is. We can really support people across this full spectrum of substance use care. And that, I think, is a novel and exciting opportunity, and one that is guided by people across the sector, people with experience, people across the province. And so I think I'm really excited for the processes we put in place. I'm excited for the work that's coming forward, and I'm very hopeful that this is going to make an impact in people's lives. And I'll turn it back over to Chris.
Yeah, so to just kind of close this out, so that's a picture of me during at the end of my, not the end of my second ride, but reaching the Atlantic Ocean on my second ride. The first picture I had sent that was on there was me, 139 pounds. I was stealing my food to eat, went 2 years without gas in my home, heating water on the stove to clean myself, curtaining off a living room to use electric heaters to stay warm for years, to then going to riding a bike across Canada and doing things that were well beyond my wildest dreams when I was taking the bus to the methadone clinic. And I share this because we can't ever guarantee the success of anybody's treatment or recovery. But what we can do is increase the margin of the possibility for success by creating as many pathways as possible to get them to a better place. And it takes time. It took me 8.5 years to get from beginning to end. And so it's going to take others time to get it. But I think if we do this right, and I think if we create as many pathways as we band together as a community, and we start implementing various integrated care pathways, I hope that it's one of your patients who's in a picture presenting of them riding across Canada to raise awareness. So I want to thank you guys so much for being here and for listening. And I really hope we band together and make this all happen, because it's really important work we're doing. And I thank you all. My hat's off to all of you guys for all the amazing work you're doing. You guys are heroes for what you do, and I appreciate all of you.
Okay, and so that is that. Let me stop sharing my screen, and love to hear your thoughts, questions, comments.
Thanks, everyone. Thanks, Hasan and Chris. I'm going to enable your ability to open your mic. But while you figure that out, I've been tracking some great questions and comments in the chat. So I'll sort of circle back to those folks who were, who had some thoughts and questions to share from the outset. The first two questions, although one was for Chris and one was for you, Hasan, have a bit of a relationship to each other. So Chris, there was a question around, peer support within the ED and how important that is. And, a question around what is the funding? How did you get funding for your role at Lakeridge Health? How do we advocate for that as communities and as organizations? And then Hasan, the next question was of a similar vein, that what you're talking about implementing within the context of the ED is something that's really desirable, but there are certainly some resource barriers as well as, corporate interest barriers, I believe was the term that was used. So suggestions for how to advocate for, receive funding to sort of implement this within both peer support and the other expectations within our services.
Do you want me to go first?
Yeah, sure.
So the funding thing is a little bit above my pay grade at the hospital, but the how I got into that position. So with Lakeridge Health, I've been on their mental health and addictions emergency care integrated planning committee for a couple years, and it was actually through there, just consulting on that strategy where I finally was just like, listen, nobody, people don't want to talk to somebody. Like, it's so much easier to get through to somebody when that person's when you can demonstrate that you've been through it, and they're like, oh, okay, you get it. Then they're going to open it up and then let it all out. And then you can get more context to give to the crisis team or the psychiatrist or whomever their next person in the line of care is. And I equated to putting two people going through a chemo sitting down beside each other. You're going to be able to jive over things that no one else in the room can, that aren't going through it. It's the same principle, different context. And it took me a few times of advocating for that at the strategic level before they had opened up the position. And before they opened up the position, they had asked me if there'd be something I'd be interested in. But they were also looking to do a reimagining of what the role can be. And they wanted me to help kind of build that up and design it, which is part of the excitement of what drew me into it. Was I'm like, yeah, I get to build a ship. So it was that's kind of how it went about for me. As far as the funding aspect, I can't really speak to that because it's just not where my experience is. But I mean, I think advocating for and I mean reasoning with people and helping them understand the value of it, because it is critical. It is critical to have somebody there who can, like I said, the more unknowns you can reduce within a hospital, with any setting really, but the less, like, uncertainty is the mother of anxiety. The more uncertainty you can reduce, the less anxiety is going to be. The less anxiety there's going to be, the more confidence in the care they're receiving. The more confidence the care receiving, the more likelihood for a positive outcome. And so I broke it down that way, and I try to, that's how I've tried to navigate it, and just trying to be the person I wish I had when I was in there. But also, I also remind everybody in the emerge, it doesn't matter if it's the physicians or everybody involved, that, listen, I'm here to support you guys. If there's a weight that I can take off your guys' shoulders and help and help wherever I can, let me know. I'm more than happy to do it. And then when they start to see you as an asset and as somebody who can actually help them out, then you start winning over the actual emerge staff, which there's a lot of personalities in our emerge department. So you gotta, so being able to kind of to show by example that your worth and what the possibilities of the role can be has been my biggest way of advocating for not only the position but for the growth of it.
Yeah, thanks so much, Chris. Just to add on that, especially the funding piece, I think, yeah, I think it's clear that there is additional investments that need to be made, and so we just, we do need to. There's only so much we can do with the same amount of resources, and so, for example, our peer support program is funded through a grant from a foundation that comes to our hospital, and we're lucky to have that. And without that, I don't think we could do that work. At the same time, there is more we could do with the same resources. So I remember going to our hospital before we started our RAM clinic and saying, we need something low barrier, even if it's just like 1 or 2 days a week, just something where people can drop in because like what we're doing is not working for people. And there was no interest and no one at the table to kind of come together on this. And then we got what is honestly like, it was like a nothing investment through Medify when all the RAM clinics in Toronto at least were kind of starting up. But suddenly with the tiniest amount of money that I actually don't think was the impetus, but it somehow brought a whole committee of people together. And suddenly I was at the table with, a VP of the hospital and people in like clinical programs and security and pharmacy, and all these different folks were suddenly there for this tiny amount of money. Like, but it was them all being at the table that actually was what helped us start our RAM clinic, not the tiny investment that kind of came from the Lin or whatever it was at that time. I can never figure out who's funding what. And so to me, I think this is some of the work that we really want to do at the Center of Excellence to say, can we get some investments into the right places and do that in a proactive way, but also can we force conversations like integrated care pathways where you need representation from the emerge and from inpatient services and from community services and the people that are going to be transitioned around these places, so that we can actually do more with the same resources we're doing, and then really make sure that our extra investments are doing the most that we can with that money.
So I'm going to shift to a question that I think might be an extension of that. So in it, a number of people asked about resourcing for these things, but one of the other questions, so even if we magically had the resources to implement the program expectations that you've outlined, are the program expectations sort of an equivalent to what were the quality standards? So is there an accountability? Because we know that having the resources to do something isn't necessarily, equate to implementation with fidelity or as expected. So is there accountability associated with the program expectations that you've outlined?
Yeah, and the plan is absolutely. I mean, there's a whole planning and performance side of the shop. Like we're on the clinical side of things. There's a whole planning and performance side at the Center of Excellence. There's a whole data and digital strategy, and the idea is, I think in so many ways, and what I'm learning kind of through a rude awakening is that there's so many things that have been funded without any clear expectation of what we get for it. And then after the fact, we're trying to figure out like, oh, is this working? Well, actually, we have no idea. Let's do a study and try and figure out what's working and what's not. And this is really meant to be like, this is built in at the start, that we're going to have a measurement framework. We're going to have expectations. We're going to have these, pilot sites, and we're going to get that data to say, what's working and what's not because it's going to be punitive, but in a way that we say, for instance, there was a long discussion we had about, should we have methadone in the emerge, because it's a lot harder to initiate kind of without a pharmacist, or what do you do at 2 a.m. compared to I can get methadone in my emergency department at 2 p.m. because the pharmacist is there, but at 2 a.m, what do we do? But if we say, based on our clinical expertise, based on patient experiences, this is the right thing to do, is to be able to initiate it when someone's ready, regardless of the time. Then we can say, okay, let's measure to see whether that actually happened, and if not, we can figure out what the barriers are, what do we need to do. And that's where I'm really excited about this shift from something far more reactive to something a lot more proactive, data driven, but still informed by values and people's experiences.
So the next question pertains to the role of community agencies in these integrated care pathways. So you're talking about investments in these program expectations within the emergency department, but if that works perfectly, you're going to be referring out to RAM clinics, community-based agencies, that provide withdrawal management or outpatient services. So what is the role for community agencies in the integrated care pathways when, if the funding is centered on the ED, and they're going to be receiving more referrals, and of course they're experiencing the same health human resource issues as hospitals are. So how do you see working with those community providers?
I'm back. Sorry, I didn't hear any of the question.
The short version is, what is the role of community providers in the integrated care pathway, because they're going to be recipients of referrals and, like hospitals, have been struggling with resourcing and health human resource issues.
Yeah, for sure. And it's a great question, and this comes up all the time. And we kind of hear it from every side, which is like the emerge saying, oh, we don't have enough resources to deal with this. The community agency saying, oh, well, we have no resources to deal with this, and it's going to be even harder if we're getting a whole bunch of people from the emerge, and our inpatient services saying the same thing. And I think ultimately, the idea right now was we have a number of resources being put into the system, but they're not talking to each other. They're very siloed. We don't know what's going on. We don't have a good kind of idea of the data around what's happening. So this is the first step, that we integrate this care, we learn about that. And then when we make those investments in community services or hospital services or emerge services, it's done because that's where our experiences and our data is showing we need the most investment. Like that's where the need is, right? So right now, people are coming into the emerge. We kind of have no idea what's happening. We just know that they get bad outcomes, and they might go to 7 different community agencies when really they just needed 1 or 2, but they needed that in the right way and they needed support in the right way. But once we integrate that care and we're getting the right data, then we can say, oh, actually what we need is, this, like the big gap we're seeing is this housing agency is not getting enough support. And that's where really, that's where people fall into the cracks. Or it might be, oh, we need actually 3 extra hours of RAM this week, because that's where we're seeing a bunch of people that just can't get care. And we can start to do that in a way that makes sense instead of just guessing at it. And I think that's where I'm really excited but the first step is, and I always kind of reiterate, is until we integrate care and we kind of do the low hanging fruit, we won't know actually where the investments are needed and where we need to actually bolster resources.
Thanks. I'm just flagging we have 1 more minute. I'm going to try to squeeze in one last question for Chris around your ability to follow clients. So if you meet with someone in the emergency department, you interact with them as a peer and support their journey in the ED. Are you able to follow them to inpatient floors or outside of the ED to support their journey?
Yeah, so that's not part of my description, though there have been 3 different people who I'd spent a significant amount of time with and who didn't see past the next couple of hours, much less the next day. And I spent time with them and slowly kind of got to the bottom of things and helped kind of start building the confidence back up, and then ended up being a C4 in Oshawa, is where our inpatient is. But I gave them my word that I would see it through with them. I'm not going to let you go. And what I would do is actually pop up on my breaks for 5 minutes, just check in, say hi, how you doing, and then seeing kind of how that meant the world to them. And then it kind of, the light bulb went off, where I'm just like, you know what, a lot of people who do get transferred to inpatient are missing a continuity of care. There's not one pivotal point where they can connect from emerge all the way through to discharge after inpatient, that there's one point of contact that they can see through beginning to end. So I have been advocating with my management to try to listen, just give me half hour of my day. Let me go talk to who I need to talk to. I'm not saying I'm going to sit down with them, but just say hi but the more I've been doing this job, the more I realize how critical that continuity of care is, from the moment of contact in emerge to all the way through inpatient and on all the way to discharge. And then I don't generally speaking do outpatient phone calls or anything like that, but I try to follow them through all the way through to discharge after inpatient.
People are patiently hanging in. I'm going to ask you one more evocative question. Answer each of you in 10 words or less. You talked, Hasan, about healthcare provider interaction with individuals who died from an opiate overdose and how frequently they're coming into contact with all of us in different ways. If there's one thing a healthcare provider can do to mitigate that, what is it?
I think it's to take it seriously, that when someone's going to self-initiate discharge, when they're uncomfortable, when they're there in the emergency department, like those are, like that is a reason to be in the emergency department. That is perfectly important reason to seek care. That visit is the most critical visit probably on your shift, and to really take it as seriously as possible. I know that's more than 10 words, but
that's okay. Chris?
Demonstrate that you genuinely have their best interest in mind, because that's what builds the trust, which then builds the confidence in the care they're getting. That will improve patient retention because they trust the process that they're going through, that this person actually cares about my well-being. So I'm going to follow them and trust what they say. That is so important that was the biggest difference between my methadone doctor and I working as a team to get off of methadone. It all circles around building trust. And that just comes in the form of just being respectful to a person. And it's actually wild to me to see how many times that's been slipped through the cracks, when you could have just said a couple nice words to somebody and that would have kept them in. Instead, now they're gone and we don't know where they are. So be kind, be compassionate, be empathetic, and treat people the way you would want to be treated.
Great. Thank you so much. Thanks, Hasan and Chris, for your insights and information. And thanks to everyone who made the dialogue at the end engaging and rich. And clearly there's lots more happening in this area, and people are keenly interested in seeing those improvements in their communities. I've pasted the evaluation in the chat there. So please do take a few moments to give us some feedback. And have a wonderful break, folks.
Great. Thank you, guys.